Good evening, and welcome to Politics in Pink 2, Black Maternal Health Matters. My name is Markia Haywood, and I am the president of Gamma Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated. GKO is part of the Unapologetically Ready Central Region under the leadership and direction of Central Regional Director Kiana W. Davis. I would like to thank Jennifer from the Carbondale Public Library for hosting tonight's forum. Social justice, advocacy, and policy reform has been a part of Alpha Kappa Alpha Sorority Incorporated DNA since our founding on the campus of Howard University in Washington, D.C. on January 15, 1908. Our international president, Danette Anthony Reed, has launched 6 initiatives under her 2022 through 2026 administration. Strengthen our sisterhood, build our economic wealth, enhance our environment, uplift our local community, empower our families, and advocate for social justice. Under the Advocate for Social Justice and Empower Our Families, these initiatives, the mission is to stand in the gap to empower our community and act in the best interest of all people that we serve. That's through social advocacy, education, empowerment, justice, and reform. We will continue to equip our community with tools, knowledge, and support to activate their voices and mobilize them to advocate for their health care rights. Welcome once again to Politics in Pink 2, Black Maternal Matters. At this time, I will bring to our virtual podium Chaplain Kimberly Smith Drake.
Good evening. My name is Kimberly Smith Drake, and I serve as chaplain for the Gamma Kappa Omega chapter, and I too welcome you to Politics in Pink 2. My meditation for this evening is to encourage you that you deserve to be in spaces and relationships that value you, that feed your soul, and help you grow. You are worthy of connections that are loving, nourishing, and genuine. This space created tonight is everything that you deserve, and you are invited to allow your soul to be nourished and therefore empowered to pursue self-love, self-care, and overall advocacy for your health and that of women in your community, city, state, and this nation. Let us pray. Heavenly Father, giver of life and health, we ask that you grant us strength, health, and peace as we pursue your truth and strategize to bring access to wholeness and healing of the healthcare disparities that exist in each of our environments. You are our strength, and we pray for strong, vigorous bodies that can easily engage in exercise and the work of our hands, and that is strong and resilient to all illness. We trust you to cover our leader, President Markia Haywood, and the members of GKO, all of our panelists, community partners, Congresswoman Lauren Underwood, and all of our guests who have joined us here tonight. Elevate our conversation that it might be enlightening and therefore productive to the furtherance of your proposed service to secure justice on the behalf of all. We pray, amen.
I'm so sorry, I was talking and I was muted. I'm Jennifer Robertson. I just wanted to let you know how you can submit a question. If you're viewing this on Zoom, you can use the Q&A function. You can also use the chat. You can send questions anonymously by checking send anonymously. You can also put questions on Facebook, and we will take a look at those as well. If you have a technical problem, you can raise your hand or use the chat as well.
Good evening, everyone. I will introduce the panelists for this evening's session in alphabetical order, and we begin with Dr. Alexis Dunham-Moore. She is a tenure-track assistant professor at the Emory University of Nursing, a certified nurse midwife, and midwifery director of Choices Center for Reproductive Health. Dr. Dunham-Moore is committed to advancing the health of those most vulnerable. Her research and service are focused on dismantling perinatal health disparities, as well as developing initiatives to address the root causes of maternal mortality. She is a certified nurse midwife who works in a variety of roles within the academic and clinical settings. Her work has improved the health of thousands of women through research and clinical practice, as well as advocacy efforts on the state and national level. She is a fellow in the American College of Nurse Midwives and actively serves on several national committees. She has published in a variety of journals, including the Journal of Midwifery and the Women's Health and Biological Research for Nursing. Additionally, Dr. Dunham-Moore actively disseminates health-related information through mainstream and social media outlets and has been featured on NPR radio as well as television broadcasts for Fox 5 Atlanta. Next, we have Senator Christopher Belt, Illinois District 14. Senator Belt is a lifelong resident of the Metro East. He holds a Bachelor of Science in History from Illinois State University and a Master's in Public Administration from SIU Edwardsville, and a Master's in Professional Counseling from Lindenwood Belleville. Christopher has been married to Stephanie Skurlark Belt for 26 years and counting. They have two children, 25-year-old Christiana Yvonne Belt and 22-year-old Stefan Christopher Belt, who is also a junior at SIU Carbondale. Christopher is an accomplished author of a children's book entitled The Adventures of Nate the Gnat. He is immediate past chair of the Senate Black Caucus. He is currently the Senate Chair of Education K through 12 and sub-chair of Appropriations for Education K through 12. Belt is a former law enforcement corrections official, as well as former school board president of Cahokia Unit School District 187. Next, we have Kyla C. Connor. Kyla is a certified birth doula from Chicago. Kyla began her journey in women's health after receiving her bachelor's in biological sciences in 2017, following her master's in public health with a concentration in community women's health education in 2020. She is currently pursuing her nursing degree. Upon completion of her nursing degree next year, Kyla plans to continue her education to obtain her Doctor of Nurse Practice as a certified nurse midwife. Kyla is the director of outreach at As She Blossoms, which is a nonprofit organization that helps incarcerated women receive access to feminine hygiene products. She also serves as a peer mentor and volunteer doula for incarcerated women throughout Illinois. She also has her own doula business called Pretty Doula Birth Services. Kyla's overall goal is to improve infant and maternal health throughout the Chicagoland area, especially within the African American community. She takes pride in being an advocate for reproductive inequalities. We have Ebony January. Dr. January hails from the great city of East St. Louis and now resides in Texas. Dr. January is a board-certified physician, author, health and educational coach, specializing in improving health disparities, advocacy, preventive medicine, weight loss, mentorship, and fitness. She received her medical degree from Wright State University Boone Schaaf School of Medicine. Licensed in 10 states, Dr. January is an appointed council member for the Department of Health and Senior Services and an extension for the Community Health Care Outcomes Hub member. She is passionate about provoking change and has authored a self-help book entitled Educational Athlete: Why Every Student Needs a Coach, to help students and parents navigate academic and professional success despite adversity. She is a recipient of the prestigious Lifetime Achievement Award presented by former President Barack Obama for her work partnering with famed Olympian and fellow East St. Louisan Jackie Joyner Kersey on a program that impacted over 20,000 families nationally with the 2015 Childhood Obesity Campaign. Dr. January continues to advance opportunities in Houston and across the globe as it relates to whole body preventive health, public health, and youth success. Removing barriers and redefining success within underserved communities is the medical doctor's rallying cry as a health and educational powerhouse. Chastity Mays. Chastity is a certified birth doula with Dona International and sits on the Black Mother Baby Committee with Dona International. She has a passion for working with families to support them with education and emotional and physical support while pregnant, during labor, and 6 weeks postpartum. Chastity has experience with home births and hospital births. She is especially has a heart for working with Black, Indigenous people of color because, quote, we experience hardships while birthing in hospitals, unquote. Chastity continues to recruit BIPOC doulas to the profession and educate on the Black maternal health crisis that the U.S. is experiencing. Monique Spears is a board-certified family nurse practitioner currently serving the Southern Illinois community as a field-based nurse practitioner for Molina Healthcare. In her current role, she provides care in the home of her patients across the lifespan from infants to elderly adults. She started her journey in nursing at SIU, where she obtained her bachelor's in nursing from SIU Edwardsville in 2015. She later pursued her master's in nursing at SEMO, graduating in 2019. Her passions are providing accessible care and healthcare insurance to underserved communities, and ensuring education is top priority. And last but not least, we have Mariana Thomas. Mariana was born and raised on the South Side of Chicago. She is a graduate of Hope College, where her organizing roots began as she advocated for inclusion of students of color on her campus. She then went on to Princeton Theological Seminary to earn her Master of Divinity. Mariana is currently the program manager for the Black Organizing Program at Planned Parenthood Illinois Action, where she advocates for access to safe and affordable reproductive health care for Black communities throughout Illinois. She is also an elder at her church, First Presbyterian Church of Chicago. In her free time, Mariana is an avid traveler, concert goer, cat mom, and beloved partner to her fiance, Alex Cooper. Welcome, welcome, welcome to our panelists this evening. I will turn it over to Kimberly Smith Drake, who will introduce our moderator for this evening.
Thank you. I am charged with the introduction of the amazing and awesome Neofantia Robinson, MBA. Although a proud native of East St. Louis, Illinois, she's also proud to have called Carbondale home for the past 16 years. Neofantia received her high school diploma from Althoff Catholic High School in Belleville, Illinois, and later obtained a Bachelor of Arts degree in communication from the University of Missouri, St. Louis. She completed her graduate studies at Webster University, earning a Master of Business Administration degree in the fall of 2012. She is currently pursuing a Master of Social Work degree from Aurora University. As a civil servant, she's employed with the Illinois Department of Human Services and was recently appointed by Governor J.B. Pritzker as a member of the Governor's Rural Affairs Council. Her community involvement includes membership in Alpha Kappa Alpha Sorority Incorporated. She was initiated as an undergraduate student in the fall of 2003. She's currently an active member with the Gamma Kappa Omega graduate chapter here in Carbondale. She's also a member of the NAACP Carbondale branch. She is a former member of the executive board for the American Federation of State, County, and Municipal Employees, Local 1048. She currently serves as a member of the executive board for the Carbondale Elementary School District 95 parent-teacher organization. Additionally, she serves at her home church, Zion Temple Church of God in Christ, as the president of the women's department. She's a proud wife of Stephen Robinson Jr., who is also a civil servant employed with the Illinois Department of Children and Family Services. Together, they have 3 wonderful children, Morgan, Madison, and Stephen III. I introduce to you Neofantia Robinson, affectionately known as Neo.
Kimberly, thank you for such an awesome introduction, and good evening, everyone. And thank you for joining us in Politics in Pink Part 2. As has been stated, I'm Neofantia Robinson, and I'm delighted to be your moderator for the evening. Before I begin, I'd like to thank my president, the president of Gamma Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated, Markia Haywood, as well as the visionaries behind tonight's discussion, the Connection and Social Action Committee. Thank you for this opportunity and for recognizing the necessity of having this discussion. Tonight, we have an array of esteemed panelists who are more than qualified to speak directly to the issues that affect Black women and maternal health. The international president of Alpha Kappa Alpha Sorority Incorporated, Danette Anthony Reed, has set forth a legislative agenda that will address 2 very critical issues. One is Black maternal mental health and the prevention of deaths among low-income and minority individuals due to suicide and substance abuse. The other is the crisis of suicide and the prevention of deaths among Black youth. As the first and premier Greek-lettered international service organization established by Black college-educated women, we will continue to monitor legislation that will address these issues. So let's jump right in. First, we'll hear from 1/5 of the panel of maternal health providers. Let's give a warm welcome to Chastity Mays.
Thank you so much. Thank you so much for asking me to be here tonight. I am honored and grateful that you asked me to be here with you. So I'm going to speak tonight about the national maternal health crisis affecting Black and Indigenous people of color. Like I was introduced, I am Chastity Mays. I have a master's degree in education, and I'm a certified birth doula. I have been a certified birth doula for about 4 years now. So I am passionate about helping all families. I love supporting families in birth. I have found my calling, and I love being a birth doula. I have experience in hospital and home birth, and I definitely am passionate about bringing new doulas into the field because right now I am the only active Black doula in Southern Illinois. I have clients as far away as Paducah, and I'm also serving the Boot Heel area of Missouri now. So I definitely want to bring more Black doulas to the area because our services are needed in the area. Whenever I get a chance, I love to talk about the Black maternal health crisis that's happening in the US, because as we will see later, the statistics are ridiculous. And that's why we're all here tonight, to speak about the Black maternal health crisis and what we can do to help. So I wanted to start my presentation off with some statistics, and then I wanted to go ahead and move into speaking about how I help the Black maternal health crisis. And then I'm going to talk about what we can all do, a few changes that we can all make to help. So I wanted to start out with some definition of terms. So I wanted everyone to understand the difference between maternal morbidity and maternal mortality, because I think sometimes people get confused when we talk about those. So you can see from the slides, maternal morbidity, and this definition comes from the World Health Organization. It is any health condition attributed to and or aggravated by pregnancy and childbirth that has a negative impact on the woman's well-being. Where maternal mortality is when a woman dies from anything having to do with pregnancy. It's called maternal mortality or maternal death. Maternal death can happen while a woman is pregnant, during labor and delivery, or in the 42 days after childbirth or the termination of pregnancy. So this first slide shows statistics worldwide. So if you take a look, this slide compares the US with 12 other countries. New international data shows the maternal mortality rate in the US continues to exceed the rate in other countries. In the US, Black women are 3 times more likely to die than their white counterparts during labor or childbirth. So if we take a look at this slide, it shows us all the other countries. So we have the Netherlands, we have Norway, we have Sweden, we have France, Canada. All of these other countries have better outcomes than the US when it comes to maternal mortality rates. And then this chart is also broke down by race. So US white women, if you take a look at this number right here, their maternal mortality rate is still higher than all the other countries. But if we take a look at Black women in the US, this rate is so much higher than everything else. Every other country and every other race, Black women are dying at high astronomical rates. Now we're going to take a look at information from the Centers for Disease Control. And this is the most recent study to come out from the CDC. This chart shows years 2018, 2019, 2020, and 2021. First, I just want to point out that women as a whole, this statistic keeps getting worse every single year. It is not getting better. And this is all women in the US. Our maternal mortality rate just continues to rise. So there has to be something going on in the system why this is happening. But then we take a look at Black women. Every year, those numbers keep creeping up and up and up. And it just continues to rise. There are different reasons why, and I know the panelists can speak to some of the reasons why we could fix these issues, but the rates just continue to rise. So because I live in Illinois, I want to talk a little bit about the statistics in Illinois. So in Illinois, a Black woman is actually 6 times more likely to die than her white counterparts. In all of the 50 states, Illinois ranks 36th when it comes to maternal care. That's not a great number. So let's just point that out. Pregnancy-related deaths as a whole are preventable. So 72% of the deaths that we see are preventable when it comes to maternal mortality. Some of the issues that we will see women die from are blood clots, heart failure, hemorrhages, sepsis, and mental health conditions are some of the reasons why women will die while they're in labor, after they have a baby, or just while they're pregnant. I know that some of us know some famous cases of people that have had issues while they were in labor. So I think one of the most famous for me is Serena Williams. Serena Williams told her doctor while she was pregnant that she had an issue and she needed them to look out for that. They chose not to listen to her, and she still had an issue. And in my mind, I think to myself, if Serena Williams had an issue, the women that I'm going to see in small towns in Sikeston, Missouri, in Howardsville, Missouri, in Southern Illinois, these women are not being listened to. I know that being a birth doula for me, I just call it like boots on the ground, because I'm visiting women in their home. I'm giving them resources, whether that's housing resources, whether that's diapers, whether that's wipes, whether that's just support, wraparound support that they need to support themselves while they're pregnant or during labor and after labor. So the issues that are happening with maternal mortality, if you are in birth work, it is actually not hard to understand what's happening. As a birth doula, just being in the room makes a difference, but you wouldn't believe some of the things that I've seen in the hospitals in this area. My clients have been told they're crazy. They've been told that they don't have a right to choose. So there's so many different reasons why we're seeing this happen. As a birth doula, I'm seeing it, and I know all of our panelists can speak to the same thing. So I like to just say, it's very clear, just put it out there, it's racism. It is harmful and deadly to these Black women when we are racist to them. Bias and racism in healthcare is a pressing and urgent public health crisis, and that's exactly why we're here tonight. I do like to read this quote from Cynthia Greenlee, because I think she spells it out so very clearly. Black women's maternal death rate has been shockingly high for decades, with few voices outside public health communities calling for action. What will it take to get people to recognize not just racial disparity in death rates, but the disparity and concern over US Black women's health and lives? I tell all my clients that we are not meant to do this alone. They're not meant to give birth alone. They're supposed to have support throughout their entire pregnancy journey. And I feel like if we are not taking care of our families, if we're not taking care of our pregnant mothers, then what are we actually doing? So one of the things that I always point out whenever I talk about the Black maternal health crisis is the history of birth work. I want to honor the midwives who came before me and who came before all the other birth workers. So some people call them granny midwives, some people call them grand midwives. These were midwives who were well respected, not only women from the South, but women all over the US. And these were Black women who provided care to poor and rural women during pregnancy and labor at a time when hospitals were not accessible to them. They were family counselors, they were breastfeeding consultants, they were postpartum doulas, they were nutritionists, and they were advocates. I want to point that out because some of these women, there was one midwife and she delivered 3,000 babies. These women carried this nation, and some of them had better statistics than we have now in the US. So I always have to honor the granny midwives. So I want to turn and talk about what a birth doula is, because that is what I am. So this definition just puts it like into a tight little box. So a birth doula is a trained professional who provides continuous physical, emotional, and information support to their clients before, during, and shortly after childbirth. I actually see my clients prenatally, and we visit up until they go into labor. I spend all of their labor with them. And then I like to spend time with them postpartum. So I go see them once a week for 6 weeks postpartum, because the more support a family has postpartum, the better that birthing person's outcomes are. So that's why I like to have my practice that way. So these are actually some of my doula families and babies. So I actually still have connections and contact with all of my clients. What I'm trying to do is create community. So not only do they have me for support, they have each other. And I like to point that out to them. So all of these families that you see are from Southern Illinois. All of these families breastfed their babies. So I kind of use that as an in. If they have a question, of course, I'm going to answer their question and be there for them. But I like to let them know, use each other as support, because when you have a new baby and you have someone else who's going through that same time period as you, it's just really important for you to reach out and make sure that you remember that you have each other. And not only do you have each other, you have your doula, you have your family. It's really important for families to always make sure that they lean on each other for support. So one of the things that I think would help change things, and just to get this information in front of providers, is I always like to talk about the Black Birthing Bill of Rights. So this Black Birthing Bill of Rights was made up by the National Association to Advance Black Birth. For me, these are just common sense things. But I have introduced this to midwives and obstetricians and other healthcare providers. And it's not just common for them to know this information. So the Black Birthing Bill of Rights lets us know that we have a right to be supported. We have a right to have an advocate. We have a right to be seen and heard on our birthing journey. We have a right to be recognized as human. We do have a right to be believed. And we have a right to be seen in our provider. I don't know if everybody knows this, but right now in Southern Illinois, we do not have any Black midwives or OBs in our area. We have a right to affordable care also. So I want to make sure tonight that everybody, if you're not familiar with the Black Birthing Bill of Rights, please look it up and pass it along to someone else. Even if you are familiar, share it with other providers, midwives, obstetricians, other healthcare providers, because we want to make sure that we put this information in front of them. I also always like to point out Black Mamas Matter Alliance. They created Black Maternal Health Week. It happens every year from April 11 through 17th. This year will be the 8th year of Black Maternal Health Week, and it brings awareness to Black maternal health issues, deepens the national conversation, and just amplifies what is happening, the policy, the research, and the care solutions that the other providers will talk about a little later in this presentation. So this is the quote that I always like to end with. I am not free while any woman is unfree, even when her shackles are very different from my own. I feel like the Black maternal health crisis is not only a Black issue, it is an everyone issue. These are our mothers. These are the women who are birthing our nation. Not only do we have an issue with the Black maternal health crisis, maternal health in the US is actually horrible for everyone because our rates just keep going up, even compared to other countries. Remember that slide we talked about in the very beginning. but Black maternal health is at a peak where we have to do something about it. I always want to leave people with the references that I use. Black Mamas Matter Alliance is an organization that you should definitely look up and be familiar with. The National Association to Advance Black Birth. Black Women Birthing Justice is another website you can go to. Policy and research is definitely on Black Women Birthing Justice website. And then the information about Illinois statistics came from the Illinois Maternal Morbidity and Mortality Report. I also want to make sure that everybody knows where to find doulas at. Everybody deserves a doula. The difference that it makes being in the room with the families. I think one of my favorite things about being a doula is I actually teach the families that they have a choice. They have a voice. I think that most of us have heard of the white coat syndrome, but the white coat syndrome is when they get in the hospital and the provider tells them something that the provider wants them to do, they don't think they have a choice. But as a doula, I can teach them that information. I can teach them that they don't have to do everything that the provider is telling them to do if it's not a medical emergency. So all these different databases are places you can find doulas all over the US. So blackdoulas.org, DONA has a find a doula, doula match, Kappa.net, and System Midwife partnered with Baby Dove to create a list of doulas across the country. It's a Black doula directory. If you take a look at these lists, you will find me in Southern Illinois, but you will also find other doulas in the area. Thank you very much. I really appreciate you having me tonight, and have a good night. Thank you.
Thank you, Chastity, for such an excellent and informative presentation. And thank you for the work that you do. At this time, we'll bring on the rest of the providers. We have Kyla Connor, Dr. Alexis Dunn-Amore, Monique Spears, and Dr. Ebony January. Before we move forward, is there anything that you all would like to comment on, or anything in particular that resonated with you all, given that you all are maternal health providers as well?
One, thank you for having me. This is amazing. This is, my topic that I love to discuss so very much because it's very important. And I saw this, honestly, I saw it coming a long time ago. But I will say she's right. It really is an issue of racism, but more importantly, or just as important, is a matter of the lack of knowledge, that we're not teaching patients. We're just, treating them as a number a lot of times and not educating them on their bodies and things like that. And that's a huge issue. So they, like she said, she's saying, okay, you don't have to necessarily do anything that a doctor tells you to do. You have the right to say no. But you also have the right for them to explain to you what is going on, making these doctors work, make the nurses work, make them do their job. And part of that is education. And I think that is one of the things that I have had much success in with regards to my patients, is making sure that I educate, and then I have an open door policy. They can send me messages on social media. It's very important that we educate and help to dispel, all of these things with regards to racism. Because if, it's one thing for you to be racist, but there's another thing for me to hold you accountable despite your, you being racist. Those things we might not be able to change. We may not be able to change someone's ability to see me as a human outside of color, but what you can change is how they treat you as a patient. So I think that's very important.
Absolutely. I love that, because we still have to advocate for ourselves. If they're, racist or not, I still have the right to advocate for myself and hold you accountable.
Absolutely.
To educate me as your patient. So thank you. Anyone else?
Yeah, thanks for the great information and putting those statistics out there. I think for us at Choices, and I'll share a few slides in the next segment to kind of talk about how we do things there, because we do have all Black providers, and I think there's some safety that comes with having that type of environment and some of the initiatives we put in place. But one of the main things, like y'all said, is the educational component, the empowerment piece, and like the initiatives we're doing at the clinic, various we call them drip campaigns, where we drip information through QR codes and teach them about how to advocate for themselves if they have to enter the healthcare system outside of our main clinic. But also making sure that they understand that with the racism component, it's not always that interpersonal piece. Sometimes it's the systemic component that you have no control over. You can't control how a hospital decides they're going to do procedures or what's going to happen to you when you walk in those doors. But how do we prepare people? It's almost like the civil rights movement. You know it's out here. You know it's crazy. You got to be prepared to enter into it, right? And so that's kind of how we operate at Choices. And I'll share a little bit more about that. But I appreciate a lot of the information that's been put out there already.
Absolutely, Dr. Moore. Thank you so much for your input. We're going to move right along with our questions. The first one is, can you demystify the medical complications that are attributed to assisted childbirth, which would be considered surgery, versus natural childbirth?
I guess
So
that would be me since C-section.
Okay.
So with regards to the different complications, one, I always consent my patients, and I teach the medical students to make sure that they walk patients through the process. And even before they get into the operating room, if they were to have a C-section, or let's say just in the prenatal period, if we're looking along those lines or not, is making sure that they know what the complications are. That's making sure that that they're at risk of bleeding. There's just different complications, whether with regards to them being infected. People who are infected bleed more. People who've had other surgeries bleed more. People who have had fibroids, they also bleed a little bit more. So there's always a risk of them needing blood transfusions, a risk of hemorrhage. That's one of our top preventable causes of death is OB hemorrhage. In addition to that, there's injury to bowel and bladder. Those are top, injuries that are complications associated with cesarean deliveries. But some people think that people just want to just cut on them, and that's not always the case, because many times having a vaginal birth is a safer route. But then there are other times when, let's say, someone is a diabetic, gestational diabetic, or just a type 2 diabetic, where they may not be a great candidate for a vaginal delivery. Some women who have a higher BMI or at higher risk for shoulder dystocia, shoulder getting stuck. And therefore they are better candidates for C-sections, but there are, certain complications associated with it. Many times it has a lot to do with their history, if they've had various surgeries, if they had endometriosis, if they've had tubal ligations, or tube removal, I should say, or reversal of their tubal ligation, then sometimes they're at higher risk for complications because they've had other surgeries and such. So those are some of the things that are associated with cesarean delivery versus vaginal delivery, but vaginal delivery is obviously not without risk. One being shoulder dystocia. Some people will come in with natural delivery, and then they're wanting natural delivery. And many times that means that they don't necessarily want an epidural, they don't want intervention. However, there are things that go along with not necessarily having an epidural. So, for example, people who don't necessarily they can't tolerate a lot of pain, we still would, if they tear in their first time moms, we still have to stitch them up. So, and sometimes even to use local anesthesia, they will not necessarily sit still, putting themselves at higher risk for injury outside of that. So there are various complications that are also associated with vaginal delivery as well.
Thank you for that. We are taking all of this information in. Before I move on, did anyone else want to comment on that?
She covered it.
She did, and covered it well.
She did that.
Yeah, no, with vaginal delivery, a lot of times, the doulas and midwives, they really, I have had such pleasure working with midwives. I really have. Many times I do C-sections with midwives, and they are absolutely phenomenal because they really know how to manage labor. They know what the labor curves are, and that's something that nowadays they're not necessarily teaching nurses, and that's very important as well. So I really love working with doulas and midwives because they know what labor is. They know the natural curve. And although on the younger side, I was trained by old school doctors and old school nurses, and they taught me how to manage labor. Like, I know this lady's probably going to need a C-section, or this lady just needs a little bit more time, So I learned those things, very early from people who were old school, that you have to know how to manage labor and you have to know what labor is. And sometimes in this day and age, there, nursing and doctors who don't necessarily know how to manage labor.
Yes, yes. If I can have this point of personal privilege, I just have to say that y'all are some bad Black women, just absolutely phenomenal. I feel so inspired. Moving right along to the next question. How do you believe that you all are utilizing your platforms to increase education regarding Black maternal health?
Yeah, I can speak to that. So on a personal level, I am a nurse midwife and a professor and a researcher. I have an app called Mama Love. It's actually a web-based platform. You can go to it right now, mamalove.love. It was created by doing focus groups with Black and brown moms, with doctors, maternal fetal medicine specialists, doulas, community organizations, where we basically created these algorithms to help people know, like, what are the things I need to be concerned about in the pregnancy that increase my risk for maternal morbidity and mortality. And so you can go in, you can select your symptoms. We try to use lay language, you know, how a woman or a birthing person would describe what's going on in their body. It has a physical health component, a mental health, as well as social risk, because there are social risk factors for some of these conditions. And so they can go through and it'll tell you, like, hey, it'll turn red and say you should call 911, or it'll say, hey, it'll turn yellow and say you should call your doctor. If you don't get them within X amount of time, you should then proceed to the emergency room. So the research that I do, I'm trying to create usable tools that could be put into the hands of Black and brown families in particular, so that they have some empowerment to say, hey, look, this was created by a researcher. This was, you know, it's saying you should probably screen me for preeclampsia and, you know, XYZ. That's not to say that it's fail-proof, but at least having those kind of resources. And then at Choices, you know, and I'll talk a little bit more about what we do there, but we really believe in what we call Black feminist midwifery, where we empower our midwives and we empower the women we care for to take ownership in their bodies, that you have the right to make choices across your reproductive spectrum, and teaching them how to do that. How do you ask the question? How do you push back if somebody tells you you need to do something that you don't want to do? So we empower them with the knowledge. And so we use that Black feminist methodology and how we provide our education, how we talk to them in labor, and if they should so happen to have to interface the healthcare system, how do you do that? How do you protect yourself, right? And so we do that very systematically through our education, through the different services we provide at the clinic.
That's awesome. I guess I can speak on that as well. One, that is amazing. I like to say that. But that's pretty much a majority of what I do is health education now. I no longer practice full time. I travel around the globe and just teach on delivering culturally competent care. I also am a state appointed to the Women's Council of the Missouri Department of Health and Human Services. So one of the things that we do there is that we make sure that we recognize these disparities and also put things into action so that we are able to assist and to decrease those numbers. And personally, what I've done is I've created some health guides to help educate women on their bodies and on their, the reproductive tract, the entire reproductive tract, and from start to finish, and even before, if you're considering pregnancy, and also thereafter. In addition to that, I do small talks called Intimate Conversations with Dr. January, and I actually have one coming up in October in DC, where they're shutting down the Kendra Scott store to have women come in. I'm educating them on various aspects. And so I basically travel around and I do those things. But I think that it's important that not only for me to sit on a health and senior services type of environment to educate the people who service our patients, but don't necessarily look like our patients, to give them insight and be a liaison between the patients and these people who are the decision makers. But in addition to that, I have to make sure that I empower these patients so that, like she said, when you go into, if you were to encounter the health system, how do you actually push back? How do you actually say, actually, can you test me for preeclampsia? I'm feeling a little warm and my water's been broken for some time. Can you check me for chorioamnionitis, that kind of thing? So making sure that I don't just let thought leaders know and the decision makers know this is what our patients are saying, and this is my input, and this is how I think that we should do these things so that we can deliver the best culturally competent care possible. But how do I also educate patients to say, okay, there's a disconnect. And so let me empower you so that you ask those right questions, get the most out of your visits, but you also get the most out of your experience, and you stay alive. You're alive to see your kids. So that's some of the things that I do.
Absolutely. This next question, if either Monique or Kyla could speak to it, what are some of the most preventable diagnoses that are encountered by women during pregnancy?
Hello, everyone. So some of the most preventable diagnoses, I would say, would be possibly hypertension, diabetes. Some of these things you can have pre-pregnancy, but also it can you can get them during pregnancy. So I will just speak on just making sure, like prior to pregnancy, getting your checkups, making sure you're in good enough health, making sure you're getting, blood pressure checks, you're getting your annual visits, and making sure your body is in well in a well-being state where you can carry a pregnancy. Yeah, that's all I got right now.
Thank you for that. Kyla, would you like to add or have something to say before we move to the next panel?
Spoke on some of the things that I was going to say as well. I did want to go back to the last question. I did have something to say about that, how I use my platform. So what I do, I just use the power of social media. It's very influential, if you all know that. I have so many people that reach out to me through social media that I don't even know. I always share any events, any outreach events, any town halls, and anything that can allow people to have access to resources to have a great successful birth, or any just education. Also, I do feel like us as my platform, the thing that we should do, and you all know this saying, if you see something, say something, and that's literally me. If I see something, I say something. So I'm saying, go to these town halls, go to these outreach, go to these webinars like we are now. I feel as though we are connected always. So everyone that's in this panel right now, or everyone that's a guest here, we should be able to use this as a resource as well, and also just keep making that connection, because it literally starts with us, for real.
Absolutely, I agree. Well, this has been wonderful. Thank you all again for your contribution, and we're going to move forward with the next group of panelists. Thank you again. You all are absolutely inspiring, and I know we all appreciate the work that you do in your local communities. Thank you again.
Thank you.
Next, let's welcome our amazing panelists who provide essential resources to our community. Once again, Kyla Connor, Mariana Thomas, Dr. Alexis Dunn-Amore. Welcome to each of you all. And at this time, we would like for Dr. Moore to tell us about her role as the Director of Midwifery at the Choices Reproductive Health Center. And if you could share a little bit about the demographics of the clientele that you service, and why you believe this clinic is necessary.
Okay, thank you so much. Can you all hear me? I'm trying to make sure I unmute.
Yes, we can hear you.
Can't hear me, okay. So thank you for this time. I do have a few slides I think that'll help me kind of summarize what we do at Choices. So thank you for having me. I'm the Director of Midwifery. So my training is, I became a nurse. I went back to school, got my master's, became a midwife. And then I later went back to get my PhD, which allowed me to get the doctorate to do different things. And so at Choices, we are a full-scale reproductive health clinic, which means we provide all services related to reproductive health. So we have family planning and wellness, we have primary care, we have gender-affirming care, we have prenatal care, and we have a birth center. And prior to Tennessee outlawing abortion last year, we also provided abortion care services all within that one model. So we believe that as a birthing person or as a woman, you have the right to decide where you fall and what services you need along your reproductive health journey. You have the right to be pregnant, and you have the right not to be pregnant, and we assist you with those decisions, AKA your choices. So at our clinic, we have a midwife team. There are 6 of us there, 6 Black nurse midwives. They provide care. We work at all of the clinics. We do birth, but we also do wellness. So we're upstairs, downstairs. We're in the Carbondale Clinic. And so I think that's really important that we have representation within the clinic of the populations that are often experiencing many of these disparities. We also have birth assistants. Many of them are up and coming midwives and or nurses, and they partner with us. And so when we do births, there's one midwife with a birth assistant, maybe 1 or 2 midwives, depending on what the patient has going on. And so we provide the care in the birth center. So I just wanted to jump a little bit to tell you about our demographic breakdown. So when we started doing birth back in 2017, we had a small number. It was a new clinic. We did about 8 births a month, really a younger population, but predominantly Black and single. And at that time, as you can see, we were doing about 30% of our births in the birth center, 30% were at home, about 40% were in the hospital. And then, you know, the other is the people that just didn't make it. They were in the car or they were in the hallway or, you know, somewhere in between the birth center, home, and hospital. Since that time, this year, our numbers have gone up. And since so many people are really looking for a place where they feel that they are protected. Many women are scared. They are concerned about dying. They feel like they're not cared for in the hospital. So we're really starting to see an uptick in people who are seeking a different choice when it comes to their prenatal experience. So right now we're doing about 12 to 16 births a month. I think when I looked at the data just yesterday, we're up to 85 births this year, which is really good for a birth center. Our breakdown is mostly in the birth center. It's about 66%. We still have about 30% that go to the hospital and then 4% at home. So we reduced the amount of home births we were doing and are now doing more of them in the birth center. And that's just because a midwife can't be in 2 places at once. As far as our breakdown, we service predominantly a Medicaid population, about 75%, about 14% are private, and then there's a little small percent, 12% that are self-pay. So geographically, where our patients are coming from, predominantly we're in the Memphis area, but we have people as far away as Nashville. And as you can see, Memphis sits on a tri-state area between Tennessee, Mississippi, and Arkansas. So we pull patients primarily for those states. Our Carbondale clinic, as you know, is right across the state line. And so I think because our biggest office is in Memphis, most of those clients are coming up from those areas. But I think we do have people coming down from, you know, like the Chicago area as well to the Carbondale clinic. So just a little bit about our outcomes. For choices, we have a 2% preterm birth rate. If you know anything about perinatal outcomes, you know that Black mothers, in addition to maternal mortality, there's a lot of health disparities in all of the health outcomes, with preterm birth being one of those leading areas. So compared to the national average, which is around 14 to 15%, we're at 2% preterm birth rate at choices. And our cesarean rate is at about 8% as compared to the national average in Tennessee and nationally of about 32%. So what that means is that for patients who deliver at choices, you're 5.8 times less likely to have a preterm birth. If you're a Black birthing parent, you're 6.6 times less likely to have a preterm birth. And if you are, your risk for C-section is really low, 5.5 times less likely to have a cesarean. We're actually in the middle of doing an analysis to look at our more recent data to compare us to the state of Tennessee, but it's still holding. We have much better outcomes when you look at us compared to the hospital system. So a little bit about the resources. What are we doing at the clinic? We're doing a lot of things to kind of quality management. We're doing chart reviews. We're doing sentinel events tracking. We do a lot of data collection. We do home visits. We are really engaged with our clients in a very intimate way. So they come in, we have 1 hour long initial visits, 30-minute prenatal visits. So for those of you who go to the doctor, normally you get about a 10 or 15-minute slot. We spend 30 minutes every prenatal visit. We go and we see them after they have their baby. So they deliver with us. They go home within a couple of hours. We do a home visit at 24 hours. We then see them at 1 week, 2 weeks, 4 weeks, and 6 weeks. We see them a lot postpartum, and we also see the babies. So we do wellness checks. We do the metabolic screening for the baby, the hearing screens, because nurse midwives, we're trained to take care of not only moms, but also neonates up to 28 days of life. So we're able to keep that couplet together, and we watch them very tightly from the time of their pregnancy all the way through the postpartum period. So to help make sure that we are safely providing this care. We do a lot of team trainings. There's a couple of pictures of the team here. We're all NRP certified, Breach Without Borders certified. We do refreshers, so we do drills. We, make sure people run through if we have a hemorrhage, what medicines do we need? What do you need to grab? How do you start the IVs? We're constantly reviewing those things. We go through and do suturing. We actually just finished our preeclampsia and hemorrhage management. We have a OBGYN who's our partnering physician, and she comes in and she keeps us up to date on the latest, whatever it is we need to do, and then we do a drill to practice it. So we are very tight about making sure that the team is trained. We also are engaged in a lot of research, partnerships, and collaborations. So we partner with, there's a birth center opening in Detroit called Birth Detroit. Dr. Grayson and I are part of the American College of Nurse Midwives as president. I'm the vice president of the organization, and we're trying to charter the path for midwifery for the country. And we just do all kinds of things. Like I told you earlier, we have the drip campaign where we're dripping knowledge out to our clients. We're asking them, what is it that you want? What do you feel is lacking? How do you feel about the services here? What are you scared about? We have multiple touch points with them throughout to make sure that we're providing the care that they really need. And of course, we have digital education materials because we're in a digital age, no need for everything to be on paper. We just try to make sure that they have access to what they need. And then we do a lot of community engagement and outreach. And I just want to show y'all a couple of the flyers to show you, we have community baby showers. We do film screenings and panels. We've done, matter of fact, we just did it's Black Breastfeeding Week. And last week we did a big photo shoot we invited our mamas to come out with their babies to do a big community shoot of them breastfeeding their babies. And so we have all these beautiful images of what it means to be a Black person having a baby. And one of the things at Choice is we want to instill joy. A lot of these outcomes, we're talking about how bad it is, and we know it's that, but how we are flipping that around is that we are creating this environment to let you know that you should be happy in birth. This should be a joyful time. Yes, it's scary and all that, but we're going to take care of you. We're trained. We're doing the things to make sure we're equipped to be able to provide that care for you. We're going to teach you how to make a choice. We're not going to pin you in and say you have to do this or have to do that. And then that brings back the joy and the empowerment and the autonomy and choosing your birth experience, because it's not a medical thing. It is an experience. And that's how we how we operate at Choices. I'll stop there because I know we're time sensitive, but that's a little bit about our clinic, and I'll take any questions.
Absolutely amazing. I believe you spoke to something concerning risk or safety issue surrounding the work that you do. Can you speak to that a little bit? What came to mind is one of the episodes of Grey's Anatomy, and how have you all seen that? When they started offering various services, the public didn't like it, and they received all types of threats and things like that. And so that just brought, came to my memory when you said that. So can you elaborate that on, just a little bit on that level as to what type of threats? And then I'm sure it's exacerbated because you all are all African-American. So
it's a lot of threats. Like I said, Choices is a full-scale reproductive model. So especially with the abortion piece, our Carbondale clinic, that's what we primarily provide at that location. And we are looking to expand that. But because of the way the laws have been overturned, we are constantly dealing with protesters or thinking about the criminalization piece. Are we going to go to, we're trying to provide a choice for a woman, but am I now a criminal? Like, it's this weird balance of trying to show up for your population in the face of how the laws are changing. So that's on the abortion, and even on the gender affirming care side. We have many people who are going through that process. But how do we show up for them when you have people trying to pass laws to not let us be allowed to do that? So that is hard. And then on the birth side, people look at being outside of the hospital as being untrained, and you're at home and it's just totally unsafe. And that goes back to what was spoken of when Chastity was talking earlier about the grand midwives, that campaign, they were who did all of the births. Y'all could see it in the movies from back then. But once obstetrics came on the scene and nursing, there was a systematic campaign targeting Black midwives, calling them ignorant, saying that they were hurting babies, that they were killing babies. And so that undertone has always been there for midwifery and for doulas, and it persists. that we are uneducated, untrained, and that because we're not in the hospital, that it must be unsafe. Well, newsflash, I trained in the hospital. I used to work alongside OBs, MFMs, did C-sections, took care of people having seizures, all that stuff. But I also understand that there is a group of people who are perfectly healthy, who don't need to be in the hospital. They don't need all those interventions. And then they get those unnecessary C-sections. So there's a lot of risk. We don't have support from local hospitals. They don't want to, if I try to call reports to say, I need to send this patient in, they just say, send them through the ER. We don't want to talk to you. I'm a professionally trained, state certified, doctorally prepared nurse midwife, and I cannot give report as a medical provider because I'm a midwife and I don't work in the hospital. So I have to just send the patient through the ER and say they might be mean to you. They're probably gonna think you're crazy for being a patient at the birth center, and they're probably gonna say something to hurt your feelings, but don't worry about it. We're gonna see you in 24 hours once you get home. Just get through it because you need to be in the hospital right now, because I can't give you what you need because what you need is in the hospital. It's an acuity thing. Anyway, I can just go on and on and on about that, but that is the hard part about doulas and midwives when you're trying to show up for patients and you want to interface that medical system. There's this roadblock, and in between, people are dying. And so we're trying to protect them and send them in, but we're scared to send them in. So sometimes we hold on to them longer than we probably should, because they're scared they're going to die in there, and it's just a mess. So anyway, y'all, we need political change. We need people to understand that people need to be operating at the full scope of their license, how we're trained.
Absolutely. I love working with midwives, I'll tell you that. And I've done some amazing C-sections with midwives, and they have told me exactly what you're saying, which is no one will take report from them. And when I tell you these people, some of you all are trained better than doctors, honestly, other than the surgical side, some of you are trained better than doctors. Absolutely. So it's so unfortunate because everyone forgets about the patient. Everyone forgets about the patient. I feel like you are such an integral part of the team, and people, due to attitudes and egos, they are forgetting that part, that you all are very well trained and that you are such an important part of the team. And it's honestly, it's hard to watch. It really is. But like you said, we have to change it from a leadership perspective, which is why, yes, I have to empower patients, but at the same time, I have to, hold leadership positions to where, okay, I have to force you all to change things.
Exactly. Absolutely. And we need doctors like you, Dr. January, who, people will listen to you. You have to have that relationship, and I hope that you're using your platform to do that, because we are growing faint and weary as midwives. Every day we're like, how much longer can we do this? Well, I can't have a person with a blood pressure of 150 over 110 at the birth center, but I got to feel comfortable sending her I need to be able to talk to a provider about that. Mm-hmm. But I can't. I have to just send her that's crazy to me. I just got to send you to the ER.
I've had to fight. I really had to fight. And I don't want to go on a tangent, but I'm with you and I'm very passionate about it, which is why, I was double and triple booked, but I stepped away because I saw it getting to this point. And I said that I wanted to be able to make change on a larger scale, which is why I made the tough decision to stop practicing full time. However, when I go in and I do have a patient and I see patients, it's sad. It's really sad. Like, there are times when I know if I had not have been there, they would have died on something that is preventable. So when we talk about preventable causes of death, OB hemorrhage, preventable. Many of these things are preventable. And unfortunately, it's egos and attitudes that really stand in the way of us delivering the best care possible. So you're already doing a bad job. I'm showing you a solution, and yet you don't want my solution. So this furthers, gets us, increases that death rate. And this is what's happening. So I absolutely am using my platform to try and make change, not just on maternal health, but across the board. But specifically because I am an OBGYN with regards to maternal health, but absolutely. And I love to work with you all so that we can increase this. And in fact, I'm one of the founders of a LPN school in DC that we're opening. And I just text one of the CEOs and I said, we have to add midwives and doulas, period. And he said, let's do it.
Let's go. Love it.
Awesome. I love it. There was a question in the chat regarding the community baby shower. They would like to know where can they send donations? How can they help? How can they be a part of those community baby showers?
So we do them in alignment with Black Maternal Health Week, which normally comes around in April. So if y'all reach out to me, I'll make sure to leave my contact information in the chat. We take donations, we will hold them at the center, but that doesn't normally come around until Black Maternal Health Week. I host the Black Mamas Matter Alliance, and so that's typically in April of every year.
All right, thank you for that. Next, we'll have Mariana Thomas. How are you?
I'm doing good. I'm doing good. Thank you.
Thank you for
Thank you
joining
for
us.
having me.
No problem, our pleasure. So can you discuss your role at Planned Parenthood, and specifically what Planned Parenthood is and what it's not?
Struggling with my mute button today. Yes, thank you once again for allowing me to be here in this space. I am the program manager for the Black Organizing Program at Planned Parenthood of Illinois and Illinois Action. So Planned Parenthood of Illinois is our clinic side of things. And then Planned Parenthood Illinois Action is our advocacy wing. And so we provide also the full spectrum of reproductive health care. We are known for providing abortion care and gender affirming care, but we also provide various like cancer screenings, STI, STD testing, birth control. I'm located in Chicago, and we are one of the largest providers of sex education in Chicago public schools. So we are trying to make sure that, echoing what Dr. Amor said, that people are aware of their choices and empowered to make their choices around reproductive health care and what people need to be well.
Awesome. Thank you for that. And then last but not least, we have Kyler Connor, who is the Director of Outreach at As She Blossoms, which is a nonprofit organization that provides feminine hygiene products to women who are incarcerated. Can you speak to us a little bit about As She Blossoms?
Yeah, so As She Blossom was started in 2020. It kind of started off with my colleague. She's on here as well, so shout out to her, Shania. But she was the founder of the organization. It kind of started with us. We were both, well, she's actually a nurse and I'm a nursing student. And I've volunteered at various jails throughout Illinois and prisons. And we saw that it was a need for not only women to have feminine hygiene products, but it was also a need for doulas in the jail system. Because you think about it, we have the issue of Black maternal and infant mortality just among the community, but nobody talks about that rate in the jail system as well. It's actually up there as well, and nobody knows that because people tend to think they're incarcerated, they don't matter. We wanted to make a difference with that. I started out as a peer mentor, training incarcerated women to become doulas so they can provide essential care to pregnant women who are incarcerated. Right now, we help get feminine hygiene products because, what was this? Actually, it just passed. This is 2023. The law just passed in 2022, to be honest, that women are allowed to get feminine hygiene products. So as of now, it's a law, but think about the years coming on, they didn't have access to much feminine hygiene products. So what we did was just create this organization and did a lot of outreach to bring in the feminine hygiene products and disperse them throughout the jails throughout Chicago or through Illinois as well.
All right, thank you. And we did have a question in the chat. Let me see if I can read that. Okay, it says, in looking at the stats comparing Black maternal morbidity, mortality in the US versus in other countries, what are you all seeing that non-US countries are doing that can be implemented here in the US?
I would say just more so better access to quality healthcare. insurance wise. A lot of people, a lot of insurance or for instance, Medicaid insurance don't cover most of the things that is needed to help us to have these resources. So I think some different countries have better insurance policies and better resources to me.
I know that other countries also have more of a midwifery model of care. They have more midwives than the US does, which Dr. Amore was talking about, that it's more of an education model and more of a community model where they spend more time with their clients. And the postpartum support is not there. So in other countries, they look after their pregnant families far after they have their children. The US, we still fight to get maternity leave. You know, there are still some people who don't even have maternity leave. So they're going right back to work after they have their children. So I know that insurance is a big deal. Having the services covered, like right now I'm a doula, and people have to pay out of pocket. I do so many clients for free because I want to be there to support my clients who cannot afford my services. And there's never going to be someone that I turn down. If they ask me to be their doula, I'm going to be there for them.
Can I piggyback on Chastity really quick? Yes, with having the access to the doula and affordability, I as well provide either a sliding scale or sometimes I do it for free. None of my services as a private doula, none of my services, to be honest, is no more than $700. Like, because I know the areas that I serve are more so underserved areas, and I want to make sure they get that advocacy and that care that they want and need rather than a paycheck. It's a passion and not a paycheck. I tell all my clients that come to me, it's a passion and not a paycheck. And if this is your line of work, you will understand why and how you're making an impact on these individuals.
All right, the next question I have is, what are your thoughts regarding traveling clinics and healthcare outreach? Do you think there's a long-term impact for communities they engage with?
You know, I think that that concept, I mean, sounds really good. I know of a midwife who did a big project over in Ethiopia, and through her project, they were working with community health workers to teach people about like hemorrhage, infection, you know, like the leading killers, and they were able to show a reduction in the maternal mortality rate, and that was used in the community. So my thought is that if you had these traveling mobile clinics, or if you had like a more community-based model, it's something I've been thinking about doing with Mama Love, taking it and turning it into a way to educate us Black women, whether that's through the sororities, the churches, teaching us like, okay, you can know, just like me and Dr. January, it's not hard to know how to recognize or know what these things, these conditions are. And so that, you know, I think that model could really work. They're using it in a lot of sub-Saharan African countries, community-based models, community health workers. And so maybe something like that would be really useful, I think.
The government actually has money allocated for this model. And I've actually helped respond to proposals for it. So it's coming. Definitely, it's in DC for sure.
Awesome, that's great to know. Did anyone else want to comment before we move on to the next question?
I wanted to say that I think that would be great, especially when I'm traveling to Missouri in the Boot Heel. These women are traveling an hour to 2 hours to get to their OB, to their midwifery appointments. So I know that that education in those small towns would be amazing, and it would be really helpful for their maternal outcomes too.
Absolutely. We had someone in the chat who also wanted to contribute to the conversation. She says, Karen Caldwell, she said, something else I recommend for women who need extra time off is to file a short-term disability claim if it's offered through their employer. FMLA is an option as well. However, women aren't paid while they're out of work. So short-term disability, women are typically paid 60% of their average weekly salary, just a way to leverage our employee benefits. Absolutely. We do have that available through the state of Illinois. So that's just something that she wanted to add. Thank you for that. Great advice, Karen. The next question is, how can the average citizen become involved in the provision of healthcare services? And is volunteer work available?
Volunteer work is always available. That's kind of how I started in this field, to be honest, by volunteering. When I first trained as a doula, I looked into many resources of like trying to get my birth. So I did Chicago Volunteer Doulas. They lead you with access to getting clients that want a doula but can't afford it. We do everything voluntarily. Go on these discussion panels like this one, join these town halls again. It's a lot of things that you can do, especially even the company that I work for now, we have a lot of volunteer opportunities that we do outreach within the community as well. So volunteer work is always available. Just make those connections and have those resources available as well.
Okay, that's great information for anyone who's looking to be a volunteer with one of your agencies. The next question, how can we broaden stakeholder support and create public sensitivity that raises awareness of Black maternal health issues? Anyone?
I got 1,000 ideas, but I feel like I'm talking too much. I would love, for us to come up with some kind of campaign. Like, we like visuals. So I think like, how we have all the documentaries that are out, just something that really strikes at like cultural ways of disseminating knowledge. I was down here in Atlanta. I just moved back to Tennessee, but I had this thing about getting with Tyler Perry. I'm like, listen, don't you want to create like I don't know, some kind of like something in the media, like the arts, like using the things that naturally come to us to disseminate the knowledge and to create a movement.
Yes.
That can empower like policymakers to actually listen, right? Because I feel like nothing changes until the public really like gets behind something and demands it. So if there's a way to generate that, I think that might be a good approach.
I think we're the same person. I was thinking exactly that probably a few months back. I'm like, why don't we use, visual to say what's going on? Like, where was I? On a plane, and they have this documentary about white coat something or other, white coat, I don't know, these med students, right? But of course they didn't look like us. But they were shining light on various things that were going on, the different disparities. However, why don't we somehow put money behind Black students or, Black physicians that can showcase and expose how bad the maternal health, rate is, death rate is bad. And so why don't we, if entertainment is what we need and what people watch, why don't we utilize that in order to help this? That's what I was thinking it a few months ago. So when you said it, I'm like, yeah, I think we're the same person.
Collaboration is definitely the key.
Yes.
Yes, I agree. And so did anyone else have any final remarks or something that they wanted to contribute? Our president said in the chat that culture drives results, and we know that it certainly does. So we'd like to have any final or closing remarks from you all before we move on to the next panel. All right, well, if nothing, thank you ladies so much. We appreciate your contributions for the work that you do. And as I stated earlier, you all are absolutely amazing, so thank you. We're moving full steam ahead. So next, I'm elated to have my friend and brother, the Honorable Senator Christopher Belt. And I think there was a typo in the information that we received from him, but he represents the 57th district. And although he represents them, you know, our folks down here in Carbondale, we feel like he represents us as well because he's the closest Democratic senator that we have, the nearest senator to Carbondale. Everyone else is Republican. So please, at this time, welcome Senator Belt and again, Mariana Thomas.
Awesome.
Thank you so much for being here. Okay, we'll dive right into the questions. There are several House bills that address maternal child health, mental health, and ensuring equity in reproductive health that have been sent to the Rules Committee, some with no action since March of 2023. Can you explain the process of what happens while they are in the rules, what is needed to move forward, and subsequently forward it to the senator and then the governor? And if you need me to repeat, that was a mouthful.
No,
You need me to
I got it.
repeat, I
I
can.
got it. So March 2023, we adjourned in May of 2023. And so usually what happens in the House Rules Committee, which is a Illinois House standing committee, they pretty much act as a clearinghouse for all the bills that come through the House, right? They, from the Rules Committee, if you're lucky enough, it gets then assigned to another committee, Revenue or whatever other committees that they have on the House side, and then you start the legislative process from there. If it didn't move, if it's still stalled, so to speak, it probably, or it could have had a fiscal note to it, meaning that it was some money, it was some money attached for the implementation for it to keep going. It could have had some language issues, some language between the sponsor and or the person that brought it to the sponsor's attention, the lobbyist, the agency, is a host of things that could have stalled it and ultimately could have just ran out of time. Again, we adjourned the second week of May, maybe the third week of May, but then we'll come back, go back in October, the last week of October and the first week of November, I think, for veto session. So it could move then, depending on what the bill is.
Okay, and then what do you believe we can do to assist in this process?
All legislation starts with advocacy, right? Someone has to be in the room, whether it's the legislator, whether it's a lobbyist, whether it's a constituent, someone has to advocate for legislation. And so I would urge you all or anyone listening for any other legislation to re-engage those or that legislator, right? Re-engage that person. Present him or her with the staggering statistics that are out there and move forward. I'm really happy in Illinois that the Illinois Legislative Black Caucus, we've brought criminal justice reform to the state of Illinois in the form of the Safety Act. We've gotten rid of predatory lenders and we've capped predatory. So you'll see all those predatory lending companies, they're gone that were charging 300 to 400, 500% interest. And we kept it at 36% interest. And we've done a couple years ago we expanded Medicaid coverage for doula services in Illinois. And so doulas get paid or covered in Illinois for the work that they do. And so unlike our neighbors, Missouri and Indiana and others, you know, we're steadily trying to expand those services and empower women and reproductive health rights for women. And so I'm really proud of the work that we do. But it starts with advocacy. It starts with somebody talking to a legislator, because we just don't know it all, right? We know a lot about a little, and but someone has to come and bring it to our attention, and then we can coalesce around it, and then hopefully move forward.
So it sounds like we just need to take the initiative to make contact with our policymakers and get involved in that way.
That's absolutely correct.
Okay.
And let me say this, and as a Greek, Black Greek member, as a Kappa, we do not use our platform, Black Greeks, the way that we should, right? All of these things that impact us as a community, you have the authority, you have the right. It's nonpartisan, it's advocacy, right? You're not taking this side, you're not taking a Republican side, a Democratic side, an independent side. You're advocating for those things that impact your community, right? And so those, if you think of the vast network that we have at our disposal, the chapters, the initiatives, then we should be moving these things. There are members in the Senate, AKA members in the Senate. There are Kappa members in the Senate. There are AKAs in the House. There are Kappas in the House. The Divine Nine is well represented. And so we need to be, we need to educate our legislators. We need to educate our people, our constituent, our neighbors. You know, the Bible says, my people are destroyed from a lack of knowledge, right? Then if that's the case, which we know it is the truth, let's disseminate knowledge. Let's disseminate information to our legislators and to our community.
And I would, if I could just add, you can also go to, I'll put it in the chat, the Illinois General Assembly website, and you can find the bills in the Senate and the House, and you can, whatever bill that is stalled, you can find out who the bill sponsor is or sponsors are, and it's always helpful to reach out to those specific sponsors, because as the senator said, like, they will know, you know, what advocacy groups need to be maybe brought back to the table, or you know, what the issue is with the bill, and then you have a better idea of how to do the advocacy around that bill if it is stalled. So that was the only thing I wanted to add, and I'll put that website in the chat.
And I'll help
Please do.
Mariana out, is ilga.gov, ilga.gov.
Yeah, she put it in the chat. Thank you for that. So the next question is, when bills are ready for hearings, how important are witness slips, given that this is a passive way to participate but support or oppose those pieces of legislation?
It's very important. Your witness slip is you basically endorsing some legislation, or you're opposing legislation. And I have, when I was the chair in the education, I would open up bills, and it would be 1,000 proponents and 2,000 opponents of good legislation, particularly in COVID times, where we were trying to help support staff out and this, that, and the other, and you had what we call organized opposition. You like to see, you like for it to be a balanced approach. So even if it's passive, it feels good to know that when you open it up, because you're not the only one. If I'm a sponsor of a bill, I'm not the only one that will see all the support or all the opposition. So it's really an endorsement. And again, through social media, through these networks, through these organizations that we are a part of, you should all sign up to stuff that interests you as a witness slip, right? I would advocate that each and every one of you You don't even have to be a resident of the state to do it. Just sign up if it's something that you support.
And I would add as well, a lot of times opposition to certain bills, particularly bills around reproductive health care, they tend to have a lot of witness slips. So having proponents of bills is really important, and witness slips are essential to that, because that lets legislators like Senator Belt know that there's a lot of positive energy around this bill. So.
Mm-hmm.
Faith Miller is faithful about disseminating those witness slips to the chapter members. So thank you again, Faith. If you want to chime in, feel free to do so, because that's your level.
I am screaming. Yes, I'm like just jumping up and down. This is so simple to do. And it's really that was my question, clearly. It's really a passive way to participate and engage in the process. So, once you set up your account, you can just, it's just click, send, and submit, and then you have a visual record. It houses how many witness slips that you have submitted. So that's why, the question for me was, why or how is that helpful? I just wanted to hear someone say the quiet part out loud, that these witness slips really help. So Senator Belt, whether you know it or not, you fell right into my evil plot. So thank you very much.
Thank you for the question. It matters.
I figured you wanted to comment on that. So thank you for that. So this next question is for everyone, not just Senator Belt, but how can we prepare communities to be ready to address the disease and infant mortality rate? I know we touched on that a little bit towards the beginning of the forum, but if we can address that, how can we prepare communities to be ready to address the disease and infant mortality rates?
From a political standpoint, you got to educate your community. You got to educate the very people that you're looking to help, right? There's so much disinformation as well as misinformation out there that they'll be afraid. It's designed to mislead you. And so people who is particularly in our community, we have a distrust of the healthcare. And probably rightly so, for the years and years of negative and bad things that have happened. But it takes people like us who look like us to tear down those boundaries, to peel back those onions, those layers to those onions. Can't nobody else do it. It has to be us. And so we have to be deliberate. We have to be intentional. We have to go out with the right information to counter the misleading information and tell people what it's about, and turn a moment into a movement. And then that's how it gets to people like me and legislators, and that's how the Titanic slowly turns on a dime.
Anyone else? Any of our doctors, would you all like to chime in on that?
No, I completely agree with Senator Belt. That is exactly what we need to do. Is what, like I said, I felt at one point that I was the only person, that saw it. I saw it a long time ago, which is why, like I said, I stepped away from practicing in 2019 because I wanted to make this kind of change on a massive level. And just early on in my career, I saw that there was a disconnect between them and our patients. And so I was just educating, and really it made change. And so I still get inboxes from my old patients that no one was educating them, and they appreciated my education. And so if we can get together and do this across the globe, then that's what's going to make the change that we need and drop those numbers.
Okay, it looks like we have a hand raised, Marquita Roper. You have the floor if you would like to go ahead and ask your question. You can just unmute yourself. Marquita, you can unmute yourself if you would like. Okay, there you are. Go ahead. I think she may be having trouble with her mute button. Dr. Amore asked, while we're waiting on Marquita, are the witness slips, Faith, you can probably answer this. Are the witness slips, is that only in Illinois?
I can only speak for Illinois. I know that Illinois has that process. I'm not sure about other states, but Senator Belt did say if you even are not from Illinois, you can lend support. And I know this is factual because the Illinois Dental Hygienists Association, which I'm part of, had legislation for access to care. And we had actually a lot of testimony come in from hygienists from neighboring states, particularly Missouri, where they were, wanting scaling assistance, et cetera. So Illinois did not want that. So we, lobbied for that, submitted witness slips, and they were coming in from different states. Other states can speak to that legislative process, but Illinois, I know, has that.
Okay. Senator Belt, do you happen to know if they have that process in other states?
I have no idea. I really don't. But Illinois is so easy to become a part of. You, as stated earlier, it's really easy. So take advantage of it.
Okay. Moving right along, are there opportunities for partnerships with hospitals and clinics to coordinate educational events for community events or community benefit for the benefit of the community?
Well, for those in Southern Illinois, I did want to let you know that my birth doula services is called Hathor Doula Services, and we are actually having a breastfeeding photo shoot this Sunday. It will be at 6 p.m. at SIU campus. You do have to reach out to me in order to participate, but it's for any Black breastfeeding mothers and their children. I also have partnered with a few other local birth workers, and we have started it's a family pantry. Mostly we want to collect diapers, wipes, and baby items. So if you reach out to me, if you like to donate and you're in the Southern Illinois region, we provide this free of service to anybody who's in need, and all they have to do is reach out to myself and my partners. So those are definitely opportunities for people to get involved in Southern Illinois.
All right, and then I think this will be the last question of the evening. I'm paying attention to the clock. In some countries, there are clear deficits in the areas of high unemployment, inadequate prenatal care, maternal smoking during pregnancy, premature births, low birth weights, high teen pregnancy rates, high rates of sedentary lifestyle. What are existing programs that can be mirrored in these areas that will help these communities, particularly communities of color?
So I work for an organization right now, and we have educational classes, and we provide incentives to join these classes. And one of the classes that we do have is like reducing or how to quit tobacco smoking while pregnant. And so once you attend these classes and, learn more, the more that you attend, you get incentives. So like the first time you come, you get a pack of diapers. The second time you come, you get a stroller. We give essential needs to the birthing mom as well. And also the families. Like we don't just only assist with the mom, we do essential needs with them as well. So that has been very impactful, because there is a lot of women that I do serve that unfortunately does have a tobacco addiction or a marijuana addiction. So we want to, again, help decrease, pregnancy complications in the future. So we help with many things like that as well.
I can talk about two quick things. Planned Parenthood of Illinois specifically has the Bridges to Prenatal Care program, which is specifically for birthing people of color. It's in 4 of our clinics, and it is basically to help specifically Black birthing people to connect with various prenatal services. So a patient would come in to one of those clinics, and we would provide like the first set of screenings, and then we would help them to connect with OBGYN if they need food assistance or anything else to make sure that they are able to progress in their pregnancy. Also, another program is the because Planned Parenthood doesn't provide postpartum care, but in Chicago, there is the Family Connects Chicago program, which is an initiative of the Chicago Department of Public Health to ensure that every birthing person has a nurse visit after 3 weeks, and the nurse is there to check on the birthing person, check on the baby, make sure that they're okay, and if they're not, to connect them with services that the city can provide to support them. So those are two programs that can be implemented in other cities throughout Illinois.
I also would like to add, I work for an insurance company, Molina Healthcare. So I would like to say, just ask your insurance companies what resources they have available. In my role, I do home visits. So I do mom visits. I can see mothers who just gave birth up until 84 days after delivery. And I do a wellness visit for mom and baby. And that includes also PHQ-9s, which is for depression screenings, postpartum checks, things like that. So making sure that the insurance companies they do have these resources, they do have the funding for it. So just making sure those things, can be available to you. We also help with social services, case managers, behavioral health specialists. So again, just reaching out to the resources that are available to you that you might not even be aware of.
If no one else has anything, I would like to mention, I'd be remiss if I didn't mention the Momnibus Act. So the Momnibus Act is the Black Maternal Health Act that makes critical investments to address social determinants of health, providing funding for community-based organizations and their growth and diversity regarding perinatal health workforce. And they also work to expand access to maternal mental health care. They address the effects of climate change on maternal and infant health, as well as approving data collection. I'm not sure if we can put that slide up or not. Okay, there it is. And so there is the link if you would like more information about that. Again, to each of our panelists, thank you so much for joining us. It's been a pleasure moderating tonight's discussion. I hope that each of you all, our listeners, have gained more knowledge, or that the knowledge that you did have has been reinforced in a way that you feel compelled to share this information with your mothers, your daughters, your sisters, and other women in order to bring awareness to Black maternal health in our families and communities in a way that is positive and impactful. So thank you again so much. And at this time, I'm going to turn it over to our president, Markia Haywood, for final remarks.
Thank you, Neo, so much for moderating this evening. You did a fabulous job. Thank you to each and every one of our panelists, our doctors, our senator. We just appreciate your knowledge. We appreciate you coming to share with our audience to provide vital information that can save us all, that we can share with our loved ones. Gamma Kappa Omega chapter of Alpha Kappa Alpha is committed to this work. We are committed to educating our communities, educating our women and our young girls on how to advocate for themselves, how to take control of their reproductive rights and their healthcare rights. And so we just ask that you all continue to stay connected with us. We have some upcoming events that will be available on our website and on our social media platform. So if you can just connect with us, we are always honored to have you. And we will also send out an email with a list of resources that were provided on this evening. So thank you once again to all of our panelists. And thank you all once again to all those who have participated this evening and joined us. We pray that you have a great day.